Today's webinar is brought to you by the Partnership for a Drug for New Jersey and is being held in collaboration with NJ Cares and the New Jersey Office of the Attorney General and the Opioid Education Foundation of America. And I thank them for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. I'm so pleased to introduce our featured speakers who are with us today for this conversation. Dr. Emily Einstein is with us. She's a health science policy analyst with the Science Policy Branch of the Office of Science Policy and Communications at the National Institute of Drug Abuse, NIDA. We also have Dr. Edouard Coupé, who is an assistant professor in emergency medicine and core faculty in the program of addiction medicine at the Yale School of Medicine. And Selena Levy, the Executive Director of New Jersey's Governor's Council on Alcoholism and Drug Abuse. I want to thank you all for joining us today. I'm looking forward to all of your presentations. I think it's such important information that we're sharing. And I will now turn the presentation over to you, Dr. Einstein, to kick us off.
Thanks very much. As mentioned, I'm Emily Einstein. I'm the Chief of Science Policy at the National Institute on Drug Abuse, and we are the top funder worldwide of scientific research on substance use and addiction. Next slide, please. So to set the stage of what we're discussing here, substance use disorder is a psychiatric condition that involves compulsive use of substances despite negative consequences. Substance use disorder can be mild, moderate, or severe. And at our institute, we usually think of the more severe end of the spectrum as encompassing the colloquial term of addiction, which is not a diagnostic term, but it can be helpful to describe the condition. Dependence and tolerance are two characteristics that may be associated with addiction, but they are not always associated with addiction. Next slide, please. Recovery is something that can be defined in different ways by the person who is individually in recovery, but we think of it as the process to change one's life in a more healthful direction toward a self-directed life. An important aspect in which stigma intersects with the process of recovery is the idea of return to use. Substance use disorders are chronic conditions, and return to drug use is an extremely common thing that happens on the way to recovery, but it is so intensely stigmatized that it often triggers unnecessary guilt and shame, and it could result in someone being lost to treatment. Next slide, please. So stigma is discrimination against a group of people that share a characteristic. And I think an important aspect of stigma around substance use disorder is this identification of us versus them. We are the scientists in my institute, for example, and they are the people with substance use disorder. And that is just absolutely not how this disorder exists in our society. The most recent data from 2020 indicate that 1 in 7 people had a substance use disorder in 2020. That isn't just opioid, that's all substances. But that means in this webinar, there would be over 100 people who have a substance use disorder this year. And that doesn't even count those who are in recovery from previous substance use disorders or those who will go on to develop them in the future. This condition is absolutely everywhere. It impacts so many people, but it's so deeply stigmatized that we don't really think of it that way. Next slide, please. Stigma around substance use disorders comes from this idea that people are choosing to do this. They're choosing these behaviors, when in fact, these behaviors are the result of brain changes that have resulted from repeated substance exposure. Next slide, please. Stigma comes from 3 main directions. There's structural stigma, the way our society is structured is set up to stigmatize people with substance use disorder. There's also stigma from others towards people who have substance use disorders. And then very insidiously, there's self-stigma as well. People who have substance use disorders often deeply stigmatize their own condition. And this can lead to effects such as avoiding care, fearing disclosure to family members and friends, and fearing disclosure even to clinicians who might be able to help a person seek effective treatment for their substance use disorder. Next slide, please. As mentioned, stigma can cause someone not to seek the care that might be able to help them. Our largest national survey indicates that specifically fearing negative attitudes from one's community is a reason that people don't seek care. But I think a more globally important number is the fact that only 10% of people with a substance use disorder will receive care of any kind. And I think this is not only related to the fear of disclosure and seeking care, but it's also related to how stigma has established structures within our healthcare system that specifically stigmatize substance use disorder and people's capacity to seek treatment. Next slide, please. As mentioned, stigma can impact people's ability to receive care. And two of the most important interventions for opioid use disorder specifically are themselves highly stigmatized. So one example of this is medications for opioid use disorder. These are sometimes seen as replacing one substance with another, and they are not used as widely as they could be. Harm reduction strategies are also incredibly important for reducing infection transmission among people who inject substances, and these are also really highly stigmatized. The overall idea around harm reduction is to keep people as healthy as possible while they continue to use substances as they approach being ready to receive care. And these are approaches such as providing sterile injection equipment and fentanyl testing strips that have been shown to protect people's health, but are highly stigmatized. Next slide, please. Stigma itself can also lead to increased substance use. Feeling stigmatized is an isolating experience, and isolation is one of the largest known risk factors for initiation of substance use and for progression of substance use to a substance use disorder. Next slide, please. An example of ways in which structures reinforce stigma is the criminalization around drug use. So this is a quote from our director at NIDA, Dr. Nora Volkov. She says that punitive policies around drugs mark people who use them as criminals and contribute to the overwhelming stigma against people contending with an often debilitating and sometimes fatal disorder, and even against the medical treatments that can effectively address it. Next slide, please. It's also important to note that stigma interacts with other factors that contribute to health disparities and social determinants of health. So those who are experiencing racism and implicit bias may also have exacerbated effects of stigma that further exacerbate health disparities. Next slide, please. One thing that we can all do to address stigma around substance use disorder is to change the way that we speak about it. So the QR code on this slide will take you to our language guide at NIDA, but I will also go through some of our preferred language. We support using empowering language and also very science-based language to emphasize that substance use disorder is a medical condition. It's also important to speak with people who have substance use disorder to determine how they would like to be described. On the next slide are some examples of person-first language. And so it's important to use person-first language in order to emphasize that a substance use disorder is just one aspect of a human being. It does not entirely define them. So instead of calling someone an addict or a junkie or an alcoholic, we use person with a substance use disorder or person with an alcohol use disorder. Another example is the concept of dirty versus clean. That indicates a value judgment when in fact you can just use medical terminology that someone either tested positive or negative on a drug test. Next slide, please. So these are the diagnostic terms that are preferred. Substance use disorder and addiction are preferred over saying that someone has a drug habit. It implies that they might have the capacity to stop when in fact difficulty ceasing drug use is a diagnostic criterion of this disorder. Next slide, please. Oh, I should also mention on the previous slide, the word abuse is one that we try to avoid entirely because it's been demonstrated to be a very stigmatizing word. This has been a bit difficult since our institute is named the National Institute on Drug Abuse, and it would take an act of Congress to change that name. But we're very pleased that in the FY23 President's budget, our name was suggested to be changed to the National Institute on Drugs and Addiction. So if Congress passes that budget, then we will have a destigmatized institute name. Next slide, please. Another important example is how we speak about medications for opioid use disorder. So sometimes these have been referred to as opioid substitution therapy or replacement therapy, which reinforces that idea that they're replacing one addiction with another. And sometimes they're referred to as medication-assisted treatment, but we prefer medication treatment for opioid use disorder because they are standard of care for opioid use disorder. We wouldn't say that someone receiving an antidepressant and counseling was getting medication-assisted treatment or someone receiving insulin and nutritional counseling. So it's important for us to talk about these medications like we would medications for other disorders. Next slide, please. And then finally, the concept of addicted babies is something that we need to work on our language around, because addiction is characterized by compulsive drug use, and babies are not compulsively using drugs. They are just experiencing symptoms of withdrawal from having been exposed to a substance. Next slide, please. So our choice of substance-related terms can influence the way that people both seek and receive treatment. So there has been some work to demonstrate that if you describe someone as having a substance use disorder versus being a substance abuser, people are more likely to think that they are deserving of medical care versus punitive treatment. Next slide, please. I think we can skip ahead because I'm using up a little too much time. So one more slide. I would say we can all do our part if we change the way we speak about addiction to start turning the tide against the stigma around addiction. But it's also very important to talk about the condition itself and to normalize discussions around substance use disorder. The language preferences that I've highlighted are ever evolving. And so I think the most important thing is for all of us to stay well attuned to the fields and how language can best be used to decrease stigma around substance use disorder. And finally, systemic change is absolutely needed. The way that healthcare and criminalization policies are structured are rooted in stigma. And so for lasting change, we need to think about restructuring some of these policies. Thank you very much.
Thank you so much, Dr. Einstein. I think the examples that you gave are things that all of us can look at, and I'm sure we've all heard and experienced. So I appreciate those really everyday examples that you shared, and of course for all of the information and resources. So thank you for that. Now I'm going to welcome Dr. Coupe. Dr. Coupe.
Yes.
Good morning. Thanks for being with us.
Thank you. Thank you all for having me. Yes, I'm Edouard Coupe, and today we're going to be segueing some to the stigma of opioid use disorder within the emergency department. Next slide. So before I begin, I should add that the only financial disclosure I have is that I was formally supported by a K-12 from the National Institute on Drug Abuse, which ended in June of 2021. Next slide. So as far as an overview, today I'm going to start off by giving you all a very broad overview of how we traditionally, at least how we care for patients with opioid use disorder within the emergency department, and overall the role of the emergency department in addressing the opioid epidemic. And then we'll get into the heart of the presentation, and what I am primarily here to talk about today is the stigma surrounding opioid use disorder within the emergency department. And then we will wrap things up with some take-home points. Next slide. So the larger question, and I think the reason why I am here today, is why should we focus on the emergency department in fighting the opioid crisis? Well, next. The emergency department is open 24 hours a day, 7 days a week, 365 days in the year. And over the course of that time, next, we see patients who may have overdosed from opioids. Next. We also have a portion of our patients who come in specifically requesting addiction treatment. Next. And then we have the opportunity to identify patients with untreated opioid use disorder who may not have already come into the ED thinking they were interested in treatment, but we have the opportunity to identify patients through screening efforts. Next slide. So our largest professional organization within emergency medicine, the American College of Emergency Physicians, came out with this paper, which is essentially some consensus recommendations surrounding the treatment of opioid use disorder within the emergency department. And essentially, the group recommended that all emergency physicians offer patients with untreated opioid use disorder treatment, specifically with buprenorphine, and provide them with a direct linkage to ongoing care subsequent to their emergency department visit. And as you can imagine, this paper as a whole really signifies how far we've come in terms of recognizing the importance of addressing untreated opioid use disorder in the emergency department and linking patients to evidence-based addiction treatment and then ongoing addiction treatment. And now, as a result of this, I think ED-initiated buprenorphine has somewhere become the standard or the gold standard of care for patients interested in buprenorphine, specifically in the emergency department. Next slide. So, as I mentioned before, within the emergency department, we see patients who are with untreated opioid use disorder, are sort of across the spectrum. However, it should be noted that most patients who come into the emergency department with untreated opioid use disorder are not, in fact, seeking a referral for addiction treatment. Last year, I published a paper of 400 ED patients with untreated opioid use disorder across 4 EDs across the country. And we found that only 15% of patients are actually come in specifically requesting a referral for addiction treatment. And we also found that many patients are challenged by multiple social risks, which further compounds their path towards receiving life-saving addiction treatment. And some of these social risks include housing instability, racial ethnic disparities, and unemployment. And many of these reasons are why many of our patients come into the ED as opposed to other more traditional routes, such as the clinic or outpatient setting, to pursue addiction treatment. Next slide. In addition to at least some of the other social risks that I mentioned before, one major phenomena that many of our patients deal with, this serves as a barrier to receiving the treatment they need, is stigma. And within the emergency department, it's no different. Stigma itself can serve as a barrier to patients feeling comfortable or safe to talk about their disease or opioid use disorder. And it can also serve as a barrier for we as healthcare providers to deliver the best care we need to our patients with untreated opioid use disorder. Next slide. So Dr. Einstein did a terrific job of really talking about the language surrounding addiction. So I won't go into too much detail here, but I would like to take this opportunity to really reinforce this idea of using person-first centered language. I think this is something we all can do to create an environment in which individuals with an opioid use disorder and individuals with addiction or individuals with addiction as a whole can feel comfortable and safe managing their disease and seeking treatment and receiving the support that they need. And that begins with using, again, person with substance use disorder, person with opioid use disorder. And this is, again, just a sample of some of the terms that are preferred to use, but there are definitely more that I have not included that Dr. Einstein has touched upon. So next slide. So a couple of months ago, our group came out with a study. We interviewed 31, and we talked to 31 individuals who were seen in the emergency department with untreated opioid use disorder across 5 ED sites across the entire country. And we found these six themes. The first of 2 most relevant to this talk, one of which is this idea of stigma, as I've touched on before. And then also this idea that many patients felt as if their pain and medical problems were minimized. And some of the other themes we've seen were that the emergency department was not seen as a source for addiction treatment, specifically for opioid use disorder. And patients really noted that their readiness to access addiction treatment was really complex, and it was time sensitive, as you can imagine. And many patients requested low barrier access to addiction treatment or on-demand addiction treatment. And lastly, one major theme that arose was that many participants noted that emergency department staff needed additional training surrounding addiction and opioid use disorder, and the overall idea that addiction is a disease and not a moral moral dilemma or a choice. Next slide. So within this study, along the lines of stigma, many participants noted that they had very stigmatizing and even traumatic experiences while they were in the emergency department, which affected their overall perception. One participant said, "I'm being shamed and treated horribly. And then when the doctor treats you like that, then the nurses aren't nice to you. They're all like, oh God, here she comes again." Next slide. Another participant noted that that the emergency department was, or a group at least, was seen as the last resort for care in a place where patients' needs were often unmet. With this one specifically saying it's one of your last options because you have no options already. So you come into this place. I know when I'm coming here, it's really probably not going to work because they look at this whole epidemic, all of us, as people who are just almost a waste of their time. Next slide. Not all experiences the patients had were negative surrounding the ED. Several of them reported more positive experiences, specifically recently, with one saying that just the fact the people that I spoke with when I was here actually were happy when they were talking to me. They were willing to listen to what I had to say and didn't have any judgment towards what I said. It made me feel safe being here. Next slide. Several participants noted that they wanted more than just pain medication when managing their medical care surrounding an undiagnosed or untreated pain that resulted from that. One stated that, "I don't need you all for narcotics. This ain't where I go to get narcotics. This is where I go to get help, the legal, the right, the way it's supposed to be, the American way. But doctors and nurses, and when you walk in, and the first thing they do is look at you like you're a dope fiend." Next slide. So it's along the same lines of stigma, there is this idea of intersectional stigma, which essentially is the presence of multiple stigmatized identities within a person or group. An example of this might be the intersection between gender, race, or class and opioid use disorder. And just as Dr. Einstein mentioned, and this suggests that really the importance of addressing social determinants of health when dealing with addiction. And evidence thus far has shown that intersectional stigma is known to further impact treatment outcomes in patients with opioid use disorder. Next. And because of this, Black and Latino individuals are more likely to cite stigma as a barrier to receiving addiction treatment compared to non-Latino white individuals. Next. So to wrap things up, one of the major reasons why I personally chose to pursue emergency medicine is that we treat whoever walks through the door, no matter what you look like, what you wear, what's in your pocket. And this remains true for addiction care. The emergency department truly does serve as a hub for addiction care for everyone. Next. Because of this, the emergency department and its staff really need to think critically about novel ways to identify patients with untreated opioid use disorder, one. And second, we really need to think critically about how stigma and our own implicit or explicit biases can affect the care that we deliver our patients, simply because most don't come in thinking about how they would or how they would want to pursue addiction treatment. And as a result of that, as I suggested before, stigma is really remains to be a significant barrier to accessing addiction treatment. Next. Again, I want to take this opportunity to reinforce this idea of using person-first centered language. This is really a low-lying fruit that we all can do to create an environment where people dealing with addiction can feel comfortable and safe talking about their disease and receiving the best care possible. Next. And lastly, there is this idea, again, of intersectional stigma, and it exists, and it is linked with worse treatment outcomes, specifically in our most vulnerable populations who are dealing with addiction. Next. So at this point now, here's my email address. Please feel free to email me if you have any additional questions. I thank you all for listening, and thank you all for inviting me to come talk today.
Thank you so much, Dr. Kupay. I have to tell you, I found the comments that you shared from the survey to be such a fascinating and transparent snapshot of what people are really experiencing. So thank you for sharing those and for the rest of your presentation. Before I go to Selena, I know there's some questions in the chat just about whether a recording of today's presentation will be available. It will be available, as well as copies of the slides. You'll get that probably end of day today or tomorrow. So I just wanted to address some of those questions. And now for our final speaker of the day, Selena Levy, the Executive Director of New Jersey's Governor's Council on Alcoholism and Drug Abuse. Selena has been a great friend and a great friend to the Partnership for a Drug for New Jersey. Our two organizations work together on many activities, but this is her first time as part of our learning series. And so, Selena, thank you for being with us today. Welcome.
Thanks so much, Angela. Hello, everyone. I'm so grateful to PDFNJ, the Opioid Education Foundation of America, and NJ Cares for making this presentation possible. And I would like to take a moment to say I was so very inspired by the outstanding presentations provided by Dr. Einstein and Dr. Kupay. Two really tough acts to follow, but very much in keeping with the message that you'll be hearing from me today. Next slide, please. I come to you today as Executive Director of the Governor's Council on Alcoholism and Drug Abuse, the JCADA, and I'd also like to reference Dr. Einstein, what she said about NIDA. We are equally, the name of our council came about back in the late 80s, early 90s. So we are also having conversations about changing the name of the council, but it's also has to be done through legislation. So, but we have brought it up, and we are hoping that that change might take place sooner than later. But in addition to coming to you as the ED of the JCADA, I'm also coming to you as the former Executive Director of the Governor's Council on Mental Health Stigma. Most who know me know that combating the stigma associated with mental health and substance use disorders is a primary focus for me, both personally and professionally. And I'm happy to say that the New Jersey Governor's Council on Mental Health Stigma was an example of New Jersey being focused on this issue since back 2005 is when I believe that council was established. It's important to say that we need to elevate the issue of stigma because the stigma associated with both mental health and substance use disorders are not just ugly, but dangerous. Because when we think about it being a barrier to treatment, untreated, undiagnosed substance use disorders are deadly and can be deadly. And that imagine leaving any other diseases and disorders untreated. We have to really start to level the playing field to understand that we need to look at it both ways. And in crossing over from the Governor's Stigma Council to the JCADA, I do have to say that the stigma associated with addiction is singular in that it has been institutionalized and fueled by the war on drugs and the criminalization of addiction, seeing it as a moral failure for decades. Next slide, please. The next few slides are going to provide a brief overview of the JCADA for those who may not know what it is, as well as its Alliance to Prevent Alcoholism and Drug Abuse. You can revisit this information and learn more at our website at jcada.nj.gov. The JCADA was established through legislation in 1989. Core functions: prevention, planning, awareness and education, and the administration of the Alliance program. Next slide, please. In addition to the departments seen represented on the JCADA, there are also public members appointed by both the governor and the legislature. Next slide, please. The Alliance program is a prevention model unique in the nation in structure, size, scope, and its ability to reach almost every community in the state, serving all 21 counties, part of the tapestry of so many of these communities, engaging a veritable army of volunteers passionate about this issue through trusted relationships at the most local level. It is important to note that the Jicata was established when the war on drugs was in full swing. We have made progress, but there is still much work to do, as there are those who still perpetuate this kind of thinking, that just say no, punitive, dehumanizing approaches that are so harmful and stigmatizing. This approach is also still embedded, as referenced by the other presenters, in some of our systems as well. But I'm proud to say that the Murphy administration is wholly committed to moving systems away from these harmful approaches to combating stigma and changing hearts and minds. And to that end, the Jicata will be working with the administration, state departments, and all of our other state partners such as PDFNJ and NJ Cares to help raise awareness and educate communities about decriminalization, harm reduction, and trauma-informed approaches. Next slide, please. I'm happy to say that in 2011, when I was still ED of the Governor's Stigma Council, the council, along with NAMI New Jersey, created the first stigma-free zone in the state, in Hoboken. So many parts of the community were engaged, from elected officials to businesses to schools, and all in between, with signs placed along the main street. It was a wonderful day. I'm happy to say that since then, the stigma-free movement has continued to flourish and expand, with stigma-free zones across the state. And I'm also pleased that there is increased participation in stigma-free zones by our alliances, underscoring the importance of including mental health in all of our discussions and efforts around substance use disorders, and addressing the stigma associated with both mental health and substance use disorders. Next slide, please. It is not hyperbole to say that stigma is devastating and dangerous. Addressing it needs to become a high priority because of the toll that it takes on people's lives. I do believe that there are some who still do not understand its impact, and that's why we are here to do everything we can to educate the public. We also know that underlying trauma puts people at higher risk for both mental health and substance use disorders, and that the underlying trauma is itself subject to stigma and shame. Self-shame and a feeling of worthlessness leads to hopelessness and despair, all of which can sadly lead to both overdose and suicide. And it's especially important to recognize that there are individuals and groups at higher risk for trauma, vulnerable and marginalized populations, groups experiencing widespread and systemic discrimination, poverty, health disparities, and other social societal factors, all putting these individuals and groups at greater risk, and why it is so important to employ trauma-informed approaches in all of our collective efforts. Next slide, please. I think this quote by former Surgeon General Jerome Adams is spot on when he said, "I think the biggest killer out there is stigma. Stigma keeps people in the shadows. Stigma keeps people from coming forward and asking for help." Next slide, please. The dehumanization of individuals with substance use disorders helps to fuel and encourage stigma. We all know that if you dehumanize someone, it is much easier to discriminate against them. But we are talking about human beings, our parents, children, siblings, friends, neighbors, and colleagues. Next slide, please. Words matter. The next two slides come out of a focus group discussion that we facilitated here in New Jersey back in 2012 with 100 individuals who had either lost or were trying to support a loved one with a substance use disorder. I asked a series of questions to this group, but the following two were the ones that I thought were the most impactful. One of the questions I posed to the group that I've included here was, what words do you think the public uses to describe your loved one? Next slide, please. I'll take a beat to let these words sink in. Junkie, loser, criminal, scum, liar. These are the real words that were offered up by these family members in real time. At first, there was dead silence in the room, but then a flood of anger and pain and even tears as they shouted out the words in rapid succession. The raw emotion in the room was palpable. While the feelings were still fresh, I then asked the group what words they use to describe their loved ones. Next slide, please. The contrast was stunning. Sensitive soul, loving father, my beautiful boy, a smile that lights up a room. This exercise was profound and meaningful for all present that day, and remains all these years later, a powerful and very clear illustration of the kind of stigma we are up against and why words do matter. It was wonderful to hear both Dr. Einstein and Dr. Coupé address stigmatizing language in their presentation, offering appropriate options that combat stigma in a factual and person-centered manner. Next slide, please. We are very inspired here in New Jersey by the decriminalization efforts by this administration and focus on harm reduction and trauma-informed efforts, because criminalization of addiction has caused great harm and played a huge role in institutionalizing the stigma associated with individuals struggling with a substance use disorder, and even those in recovery and family members. This quote by journalist Maya Slavovitz is certainly apt. Criminalization supercharges addiction stigma, and stigma is one of the biggest obstacles to recovery. Next slide, please. Dr. Nora Volkov, director of the National Institute on Drug Abuse, NIDA, presents a critical fact when she says, the research is unequivocal that putting someone who is addicted into prison or jail actually exacerbates their condition and puts them at much greater risk for relapse. Next slide, please. Medication-assisted treatment. We also need to address the stigma associated with medication-assisted treatment, MAT, as well as the related myths and misinformation, so that all individuals with substance use disorders are always provided with all of the options available to support their recovery, just as individuals with any other illnesses are offered all options available for their recovery. Next slide, please. We can all play a role in combating stigma. Here in New Jersey and across the country, we can break down barriers, inform systems, change hearts and minds in our communities by having honest and sometimes tough discussions and conversations, but by raising awareness and educating family, friends, and neighbors and colleagues about the facts and respectfully offering alternatives when they engage in the kind of language that is too often hurtful, dehumanizing, and perpetuates stigma. Our Alliance to Prevent Alcoholism and Drug Abuse and our partnership with all the state departments and other stakeholders across the state allows us a unique opportunity to do this work on the most local level. And I have to say that those who do use stigmatizing language or may not have all the facts together may not even realize what they are doing or the harm that they might be doing. But I find that in most cases, people do welcome the opportunity to learn more. Last slide, please. Thank you to our hosts, my esteemed fellow presenters, and to all of you who took the time out of your day to tune in. I now consider all of you ambassadors who will help us in our efforts to combat stigma. Thank you, Angela.
Thank you, Selena. Those words that you shared are just so powerful, and I think really sum up why we're all here today. So thank you. We will go, I know some of you have submitted questions in the chat, so I'll bring those to our presenters now. Just a few questions before. I know that you have asked regarding credit information will be provided at the end of this presentation, and as well as a copy of the slides will be available and the recording of the presentation. So I know there's been a lot of questions on that. Dr. Einstein, I'm going to start with you. We have a question from one of our attendees that says, I work in a healthcare setting, and there's so much stigma associated with asking for offering naloxone or medically assisted treatment. Is there some terminology or strategies I can use to help reduce this stigma?
That's a great question. And I think part of that is just trying to normalize the idea of naloxone access being a key life-saving tool. I'm not aware of any research, at least, around different ways to describe it, but I think emphasizing the fact that this is a tool that everyone should have could help destigmatize it. I mean, I think all of us should be carrying it as well. And it's not just calling out someone specifically because they might be at higher risk. yeah, I think that that is a really tricky example of such an important harm reduction tool that we have that is so deeply stigmatized.
Thanks. And Dr. Coupe, I know with your research and experience, is there anything you want to add to that?
Yeah, I completely agree. I think normalizing it, I think frequently in the ED for us, it's really become a standard in terms of offering everybody naloxone. We haven't gotten to the point, at least, where we offer every patient that comes in naloxone. However, every patient who comes in with any sort of behavioral health or really addiction related concern, we essentially offer, we give naloxone without even offering it. So it just becomes the standard. And that includes in our emergency department, we also have staff who are really designated to talk about addiction with our patients. And so any patient that comes in, again, not even with an addiction related concern, but may request addiction treatment, we have staff that are trained to really talk about addiction. And so I think as much as possible, if you can make this a normal and the standard of care, I think that only then will we start to see some of the benefits of really removing this veil of addiction, stigma at least, surrounding this really devastating disease.
Thank you. And Selena, kind of a follow-up question for you. How can we make changes on the community level? What does community level involvement look like within the municipal alliances or other community level groups? And what are some effective strategies that you would recommend or you have seen?
Well, I'm going to just take a minute to just talk a little bit about naloxone and even Matt about the fact that how stigma is so embedded in everything, and that saving a life should be standard. And yet the way some folks look at naloxone or even Matt, it is that the stigma is making some lives seem less valuable than others, which is horrific when you look at it that way. And I think the normalization of saving a life on a basic level and making it every life, right, is important. And I think so I'm sorry, I just needed to say that because I think that what we're facing,
absolutely.
The challenge we're facing is that there are decades of this embedded in the way we look at individuals with substance use disorders. So I think that on the community level, you're going to see different outlooks. I mean, the beauty of the Alliance program is that it serves so many, almost every municipality in the state. And I often call this the United States of New Jersey. We know that we have such different populations across the state, different demographics. And the value of our alliances or any local efforts is local relationships that are trusted. And so I think that what we're going to try to do, and I think what everyone should do is in talking to, it's as basic as in talking to family members, people that in the workplace, schools, the relationships within the community and the conversations that need to be had, as the other two presenters, Dr. Einstein and Dr. Coupe, said, normalizing this conversation. I think that by flooding our communities with facts and building empathy and building an understanding about substance use disorders, we have to change the way people look. I think the expression changing hearts and minds, it's something that this administration, that the Murphy administration, it's language that they're using, is that the only way to really end stigma is to change hearts and minds. And so I think that the strategies, we welcome new additions to our local alliances. You can come on our website and look up we have an alliance, we have a coordinator, a county coordinator in every county that you can reach out to. Their information is on our website if you'd like to join your local alliance. So we would like to see more people involved in this effort and more people talking about moving away from this punitive criminalization approach. Again, we're very fortunate that the Murphy administration is fully invested in that. And that I think that a lot of it is pretty basic and human, of informing people, providing education. And when you see people using poor language, there is a respectful way to inform them. And I do still believe in the goodness of human nature. And I do believe that most people do want to say the right thing and do the right thing. And I think they welcome the education. I don't know if that, I hope that I answered your question.
No, it absolutely it did. I think it was right on point. And I just want to open that question up to Dr. Coupe and Dr. Einstein as well. Dr. Coupe, we'll go to you. Strategies within the community or even within your healthcare setting in the emergency department. Anything you want to add?
I think the importance, I think, really is to train staff as a whole to really understand that addiction truly is a disease. I think beyond this, beyond the fact that it's this myth that it's a choice, I think that we still have a lot of staff who still believe that implicitly or explicitly. I've seen. So I think that's training, I think, as a whole. And I think providers as a whole, now that some of the restrictions are lifted, I think it's important for healthcare providers as a whole to get their expert training so they can prescribe buprenorphine. I think that's huge in terms of addressing addiction. I think it would be hard to say we can treat addiction if we cannot prescribe the medications to address addiction. I think as an example, it would be if we had an epidemic of diabetes and doctors chose not to prescribe insulin. That would be insane. You know, the country would be in an uproar. And I think that's where we need to be at with opioid use disorders. Recognize that, like, we have medications to treat this disease. We should prescribe them. Buprenorphine, methadone, naloxone, and I think recognizing that it's not a one size fits all, and that I think that we have a host of treatments available out there, and it's a matter of really discussing with the individual to figure out the treatment that works best for them. I know in terms of looking at larger community efforts, there are mobile treatment vans that I think that are available across the country that essentially meet people where they are and link them into addiction treatment and dispense naloxone. So I think there's definitely some benefits to bringing treatment to where people are, particularly our most vulnerable patients. And I think that, and I think really getting buy-in, I think on the hospital level, getting buy-in from, when I say staff, I mean from social work to patient technicians, to obviously nurses, physicians, physician associates. I think the entire spectrum of hospital staff needs to buy into this notion that addiction is a disease, and really addressing the social determinants of health. And we touched upon, I know that is a term that has been used frequently today, because I think that still remains to be true, that there are a lot of factors externally that affect communities' ability to pursue addiction treatment, be it stigma, be it transportation, be it finances, be it access, be it insurance issues, whatever it may be. And so I think really looking at the individual overall and deliberately addressing social determinants of health to really expand access to addiction, I think is really enormous. And I think also looking at, and throughout the process, looking at again, our most vulnerable patients who may not have regular access to a healthcare system, and recognizing that like a prescription might not do for certain patients. It might just be actually giving naloxone to them directly in hand, more so than just a prescription. And the same goes with buprenorphine. So, yeah.
Thanks. I know we have a lot of practitioners on with us today, so I think those are some really helpful tips. And Dr. Einstein, I know you shared the QR code to some resources. Anything you'd like to contribute on some strategies or ways to change the community conversation around this and impact stigma?
Sure. So that's an active area of research that we're supporting right now because different communities may need different strategies in order to enhance provision of evidence-based care and reduce stigma. So our largest study in this area is called the Healing Communities Study, and it's looking at 67 urban and rural communities in 4 states that were hard hit by the opioid crisis to determine the best ways to tailor strategies to reduce stigma, especially around naloxone and medications for opioid use disorder in those communities. Wave 1 of that study is going to be finishing up this summer. So when wave 2 begins, then we're going to start to have hopefully very impactful data that can inform approaches in similar communities across the country. We're also supporting a study called the Justice Community Opioid Innovation Network, which intends to improve addiction care within carceral settings and then in the transition back to the community. So there are also aspects of that study that are hoping to help destigmatize treatment around substance use disorder in those really important settings that tend to have a higher proportion of people who need that kind of care.
Oh, thank you so much. And I guess I'll go, Selena, back to you to start on this question. Can you talk about how harm reduction efforts help in eliminating stigma?
Well, this is something that is a high priority for this administration, raising awareness about harm reduction, expanding harm reduction centers. For those who may not know what NIMBY means, the acronym is Not in My Backyard. And there have been challenges, as always have been, for facilities and in communities that are addressing individuals who are dealing with a substance use disorder. I think that harm reduction, if you think about harm reduction, if we did not practice harm reduction in our lives in other ways, the results would be devastating. So it's about mitigating harm, do no harm. It seems like it's just something that should be basic, but I do believe that in establishing more harm reduction centers in the state, in raising awareness about how harm reduction helps people along the way through a journey, through their journey, if they're struggling with a substance use disorder, if they have family members. I think it's the greatest way to humanize and live and address stigma, so that we understand that harm reduction saves lives, improves the quality of life, and it should be an approach that is used for anybody who's dealing with a disease, and especially substance use disorders. And so we're partnering with the Department of Health is focused on this, the Division of Mental Health and Addiction Services, and this administration. This is a priority, and I would hope that we hope to educate communities, and we would like to see communities come out in support of expansion of harm reduction centers in the state, and to learn more about it, because the more you learn about harm reduction, the more you break down the myths and stereotypes that are associated with substance use disorders.
Dr. Einstein, would you like to comment on harm reduction strategies and their impact on stigma?
Absolutely. I think it's an exciting time for harm reduction. It is the first time that the federal government has been willing to use specifically that terminology. And I think we are, I know we are starting to fund a lot more research about novel harm reduction strategies as well. So as I mentioned, syringe services are so important. Fentanyl test strips are an emerging way for people to be able to test for fentanyl, and especially their stimulant drugs, which is incredibly dangerous for people who don't yet have opioid tolerance. And then, as people are probably aware, overdose prevention centers have opened in New York and will open soon in Rhode Island. So we will be supporting research to determine how that strategy impacts substance use disorder and overdose outcomes in the United States, since that's been a strategy that has mostly been used in other countries. But the the stigma really remains quite strong around these strategies. And I think it's important for us to emphasize as much as possible that there is good data to show that these strategies do not increase drug use. They help keep people healthier until they can get treatment for their substance use disorders.
Thanks. Dr. Coupe, any comment on harm reduction as a, and its impact on stigma?
I think these are all great points. The only thing I have to add is just that I think is to healthcare providers, I think as a whole, we should be very knowledgeable about injection drug use and how our patients are injecting drugs. And so their needle exchange sites, I think that not everybody might be ready to pursue medications for opioid use disorder at that point. So we should understand how patients are injecting drugs and what's the safest way possible to do it. And as Dr. Einstein mentions, I know there's this myth or idea that this potentially could encourage or promote injection drug use, and that's completely false. There's no research to suggest that. And so healthcare providers should be able to take opportunity to educate patients about how they're using drugs and how we can really reduce infection and death, and that's really what our role is to keep our patients healthy. And it may not be linking them into buprenorphine or methadone or any of those other medications at that moment. It may just be encouraging our patient to use clean syringes as opposed to syringes that have been previously used. So thank you.
Thank you. And I know a poll had launched a few minutes ago. So if you could take a minute to complete that poll, we appreciate getting your feedback. I'm going to go to one last question to all of our panelists before we end today. And Selena, I'll start with you. What is, we have attendees who are on from community groups. We have doctors, dentists, and nurses. We have people who are personally impacted or their family is. What is one last thought or message you'd like to share on what we all can do to help eliminate stigma?
So again, my combined experience with the Governor's Council on Mental Health Stigma and the JCAHTA is something that Dr. Einstein said is this them and us attitude toward all of this, is to understand that we are all vulnerable at any time, to understand the role trauma plays and who we are and where we are on putting us at risk, to not ignore the COVID epidemic, the COVID pandemic, right? How it impacted us and how it impacted our mental health. I think that when we talk about substance use disorders, we cannot leave out talking about our mental health, underlying trauma. I think that decriminalization is essential. Punishing someone, imagine punishing someone for having a disease. I think that, again, we're very fortunate that this administration is wholly focused on expanding harm reduction centers and raising awareness and teaching the community what harm reduction actually is. Dr. Einstein said is very true. If you think about the fact that a few years ago, people wouldn't use the terms, government wouldn't even use the terms harm reduction. So we are at a very good point of the beginning of having this conversation the right way. And so I think that if we focus, I think that the only way to eliminate stigma is to educate people and to normalize this and to put substance use disorders on the level playing field with anything else that we experience. But again, the pandemic was a societal trauma that we've all experienced, and we are all vulnerable, and we all know that we don't always see the effects right away, and they can be seen for years to come. And so I think that focus on both mental health and focus on approaching substance use disorders through a lens of harm reduction, decriminalization, and trauma-informed approaches will set us on a path that will really help to reduce and maybe even eliminate the stigma associated with it.
Thanks, Helena. Thanks. And thanks again for being with us today. Dr. Einstein, any last comment for our attendees?
I do think the number one way to reduce stigma is for people to be exposed to others who have experienced a substance use disorder. And so making our society a safe place to talk about these things is really necessary. I think one practical way to achieve that is to better integrate treatment of substance use disorder with general medical care and to speak about it in a really objective and clinical way and get people the help that they need. But for all of us individually, that step of changing the way we speak about substance use disorders is an important one.
Thank you. And again, thanks for being with us today. And Dr. Coupe, we'll end with you. Last thought?
Yeah, last thought. I think that I just want to reinforce this idea of intersectional stigma. I think initially, when the opioid epidemic, when the media started covering it, I think within the media there was an image where it was the opioid epidemic predominantly affected white suburban neighborhoods, and I think now that narrative has shifted dramatically, and I think now it affects so many different communities and it's so pervasive that I think we all need to recognize how from rural communities to gender nonconforming communities and to Native American communities and among Black individuals, the rate of opioid overdoses actually now outpaces that of white individuals. So I think to be very mindful of the intersection of all of these other identities that are previously stigmatized that can affect someone's path towards getting the best care that they need and really addressing that. And I think all the panelists, I think we all can agree the importance of addressing social determinants of health and really care and to really deliver the best care as possible for individuals with opioid use disorder. Really, that would be the best way to expand access is to really focus on social determinants of health along the way. So, yeah.
Thank you. And again, thank you to all of our participants for joining us today, all of our expert panelists. We're going to continue this conversation on May 26th as we look at the opiate epidemic and a focus on vulnerable populations. We had started this conversation during last year's learning series, and there was such a interest, and obviously it's a high priority conversation. So please register to join us on May 26th. For that conversation. Again, I want to thank our expert panelists. You all provided such important information and really practical everyday tips that we can use at the community level as well as in healthcare settings. So I want to thank all of you again for being with us. Thank you for our attendees. I wish everyone a good afternoon. Be well. Have a good day, everyone.